It's my pleasure and privilege to introduce today's speaker, who is an alumni from our department, was a graduate student here. Started just after I started, actually, as a professor, I think.
Y2K.
Yeah. And as usual, I'm going to keep my introduction very short because we have very little time. We want Jenny to have as much time as she can. I'll just say, I guess, two things. That so she is the chief scientist at the Challenging Environment Assessment Lab, and I will say she is the inaugural chief scientist. So she started this, she built it, she created it, she runs it. So that's one thing. And the other thing, if you have any opportunity to talk to Jenny, she is an amazing academic, wonderful person, and a fabulous human being. So please help me in welcoming Jenny Campos.
Wow. Oh my gosh, that is quite the introduction. Thank you, David. It's always amazing to get an invitation to come back to this department because this is where it all started for me, and this feels like home for me. And I was just saying to Bruce and Hong Jin that in many ways things feel quite different from when I was here, but mostly they feel the same. And I just feel like it was a huge privilege for me to have done my grad studies here, and I'm all the better for it. So I will tell you today about some of the work that I'm doing at the Kite Research Institute, which I'll give a little bit of a highlight about what that is to put it in context. Looking primarily at understanding how the brain integrates information from what we see and what we hear and how we move all at the same time to support complex everyday tasks. So for those of you who are not familiar with the Kite Research Institute, it is a research institute that's part of the Toronto Rehabilitation Hospital. So it's embedded within the hospital. Toronto Rehab is part of a bigger group of hospitals that you're probably familiar with called the University Health Network, which includes Princess Margaret and Toronto General and Toronto Western. And so there are a group of teaching and research hospitals that are fully affiliated with the University of Toronto. But at Kite, we do a lot of fundamental work, but we do a lot of applied work. It tends to have some translational focus in terms of changing practice, informing policy, creating product. Three kind of general pillars. One is prevention of illness and injury. The second is restoration of function, which is what people often think of when they think of rehab, is if someone's experienced an illness or injury, how do they get back to their preferred level of functioning? And then also like aging well and having good quality of life in the community. So a lot of what we're working towards is actually quite a bit broader than rehab and quite a bit broader than clinical research, including, as I mentioned, a lot of fundamental research. And it's very interdisciplinary. So we have a lot of engineers and computer scientists working with psychologists and occupational therapists and physiotherapists. I've put a few QR codes on my slide, so if you want any more information about what I'm talking about, you can always scan those. I joke about this, sort of. I'm gonna play a sizzle video. It's kind of loud and it has fun music, and because it's 2:30 in the afternoon, I think that it also wakes people up. But it gives a bit of a context of Kite.
I'm ahead of the game. Up my rocker, but follow me. I'm ahead of the game. I'm ahead of the game. I'm only ever slinging. I'm working overtime. Got a song and I'm the singer, the melody, the vibe. I'm a prodigy, logically. I'm impossibly wanted. Then they'll remember my name. They'll remember my name. Said you know I always bring it. I'm finer than the wine, and the clock is always ticking, getting until the time. Go because you can walk with me. I'm a rock. You can roll with me. I'm ahead of the game.
Okay, so I apologize, because if you're like me, that song will be in your head for the rest of the day. But what you might have caught glimpses of throughout that video is the Challenging Environment Assessment Lab. So David gave me far too much credit coming up with the lab and running the lab and everything. But I do help coordinate the research program for this lab, and I am the inaugural chief scientist. But what it is it's a collection of simulators, essentially. So we have Winter Lab, Driver Lab, Street Lab, and Stair Lab. They're all individual labs. They're all individual modules that can be used independently of each other, that each serve unique purposes. And then we also have a motion platform. So it's a 6 degree of freedom motion platform, and all 4 of those labs can go onto that motion platform. They don't have to, but they can. So you're seeing on the motion platform right now, that is Stair Lab. Sometimes we'll put Driver Lab on there, Street Lab, et cetera. Why do we have a big motion platform and a rehab research institute? Because we want to study real-world problems under common challenges. So one very intuitive example is with our driving simulator. If you want to experience the true accelerations that you get in the real world when you're turning or accelerating, putting Driver Lab on the motion platform makes a lot of good sense because it increases fidelity and the realism of the experience. But sometimes we want to just change the inclination of the ground surface. So in Winter Lab, we do a lot of studies on mobility in winter, including footwear testing. Walking in the real world is not, it's not involving walking on flat surfaces all the time. It's walking on slopes and cross slopes. So we can put this on the motion platform and we can change the slopes and cross slopes and look at how people can manage mobility under different situations. And then sometimes we want to look at the built environment. So Stair Lab is a good way to study different aspects of the built environment, including, for example, the geometry of stairs, like the run and the rise, and the characteristics of the handrail. We want to know, for example, is a handrail going to prevent you from falling? So we could have subjects walk up and down the stairs a whole bunch of times and wait for them to fall, or we can put it on the motion platform and put them in a harness and disturb their balance and see whether or not they can make a good grab reaction to prevent themselves from falling. So this is the general kind of idea of why we might want to have a motion platform. But we've got Street Lab, which is our multisensory simulator, Driver Lab, which is Canada's most advanced driving simulator, which I'll show you a little video of, Winter Lab, where we can study, again, mobility-related aspects of winter safety, and then Stair Lab, which is our built environment lab. So here's just a little 30-second video of Driver Lab.
I'm Anna, and today I'll be your host. Driving can get harder as we get older. The good news is that we're working hard to understand how to keep people safe on the road. Welcome to Driver Lab. Come, join me, don't be shy. Come on, let's go for a spin. Feels just like a real car. How do we do it? You're totally surrounded by screens. When you turn, the whole car turns, and this is the motion platform. Thanks to these hydraulics, the whole lab moves. This makes the people inside feel like they're really driving. We can even simulate tricky conditions like blinding headlights and rain. It was nice meeting you, but I'm late for my class. Bye!
Okay, so that's Anna. She's our institute director's daughter. This is for our youth outreach program. And no, she is not legally able to drive, although probably now she is. So despite the fact that we have all of these different simulators and I help coordinate the broad research program, my own research program is really focused on multisensory integration, and I'll explain what that is. But really it's a matter of understanding how the brain is integrating signals from all of our different sensory systems to make sense of the world. I primarily look at how multisensory integration supports mobility-related outcomes, so how the senses support standing balance, walking and gait, and also driving mobility. And I also look at this across a number of different populations. So I look at healthy young people, healthy older people, individuals with dementia, persons post-concussion, and also older adults with hearing loss. And I'm not going to talk about all of them today, but I will touch on some of them today. So typically in in research and in clinical application, this is typically how we treat our senses, which is in silos. So we study vision most often separately from hearing, separate from our vestibular system, separate from touch. When we talk about this clinically, we go see our audiologists, separate from our ophthalmologists, separate from our physiotherapists. So there's not a lot of convergence in terms of how we're studying the senses and how they work together. But of course, that's not how the brain works. That is not how the brain treats sensory information. The brain has this extraordinary responsibility and capacity to dynamically, automatically integrate from across these senses to make sense of our world. And it's not trivial, and it's a complex process, and it is defined by so many different factors. And so, and it basically is contributing to everything that we do. So the fact that you're able to actually sit here right now, upright, without falling over, and listen to me and watch me means that your brain is seamlessly doing that on your behalf without you realizing the complex processing that's happening in order to allow you to do that. And so in my research, I look at how the senses are integrated in the context of mobility. So how do we integrate what our muscles and joints are telling us with what we hear, with what we see, and with our acceleration detectors in our inner ear, or the vestibular system. And so usually it's the case that we benefit from having multisensory inputs. So when the information is congruent with each other and is telling you the same information about the same objects and events, then we usually have a boost to the speed at which we can react to things and the accuracy with which we can react to things, compared to if we only had one sense or the other available to us. But the way that we do this changes dynamically. So you may have heard people say, humans are visually dominant, or something along these lines. But the thing is that the weighting of the sensory information depends on a lot of different factors, one of which, of course, is the reliability of the inputs. And we know that our environments are changing and have different reliability. So at night, visual information becomes less reliable than it does during the day. When you have lots of auditory or acoustical noise in your environment, then visual information may be upweighted. And so the brain actually, we know, dynamically weights information depending on the reliability of the sensory inputs at any given time. And layered onto that, a lot of my work is looking at older adults, for example, is that not only are our neural systems noisy, not only are our environments noisy, but sometimes we have age-related changes to our sensory systems that can also change the reliability of our inputs. So visual acuity usually declines, hearing acuity usually declines with age, for example. And so it becomes even more important to use multiple sensory inputs because we have a lot of sort of reductions in reliability. And it also happens at the level of the brain. So for instance, post-concussion, we also see difficulties in the ability to integrate across our senses. And so as I mentioned, when we're younger and healthy, the brain has benefits from integrating across all of these signals in order to make an estimate, for example, about our self-motion through space. But when you get older, a lot of the evidence suggests that older adults have heightened multisensory integration. They're super integrators. And so this may seem counterintuitive at first, but it's because, presumably, possibly because when you get older, you usually have declines across all of your sensory systems. So they may not be clinically significant impairments or disease, which can also happen with age, but we have typical sort of age-related declines that happen across our sensory abilities. And so when you have poorly reliable signals, the benefits of combining them is maximized. If your vision was super, super strong, and you had a sound cue, it's not going to benefit you much because you could have just done it with vision. Same thing with hearing. You have a super, super strong sound cue, you almost don't need to see it. You can do just as well with hearing it. But once those two signals are poor, the benefits of both seeing and hearing are amplified, and that's often what we see in the context of aging. And when we look at this from the basic principles of multisensory integration, it maps onto something called the principle of inverse effectiveness. And what that principle indicates is that when you have weak signals, they're more likely to be integrated than if you have strong signals. And we see this at the level of, these principles apply at the level of a single multisensory neuron in the brain, in addition to behavior. And then when we talk about what happens if you do have a clinically significant sensory loss, so you have, you're blind or very low vision, or you have hearing loss, it becomes, of course, even more important that we use our other sensory inputs for compensatory purposes. And the other thing is that sometimes you have sensory conflicts that happen in your environment. So, you know, the classic one is if you are watching a movie and the soundtrack is off, right? If there's, that's a very obvious conflict, but there are more subtle conflicts that we're sort of having to deal with every day. And when you're presented with slight sensory conflicts, if you are heightened integrators, you technically should probably not integrate those signals because they're in conflict, but you're going to do it anyways, and that could have complications, consequences for your perceptions and behavior. And so as I mentioned, a lot of these principles have been seen at the level of a single multisensory neuron in the superior colliculus, for example. They've also been seen for very simple psychophysical tasks, very kind of reductionistic flashes and beeps. We see a lot of these principles apply in multisensory integration. But a lot less is known about whether these basic principles in these reductionistic settings apply to real-world behaviors, including complex behaviors like mobility. And so there's a lot of advantages to doing reductionistic testing and measurement in a sound booth, with a computer, because it's super highly controlled, right? So it's highly controlled, it's safe, you can study things mechanistically in very careful and controlled systematic ways. So there's huge benefit to that. But ultimately, for a lot of things, not everything, but we would like to know how this translates into the real world. So simulators allow us to do that in the sense that they provide a middle ground where they're controlled and they're safe, but they also inject elements of ecological validity and realism in the ways that we can study these things. Okay, so I'm going to start off with driving. And the reason I'm just going to show you a really simple experiment that we did a while ago. And it was kind of our first forays into seeing whether or not these basic principles of multisensory integration applied to these more complex tasks. And we looked at driving. So I'm not going to tell you for every study who are the participants in our studies, but I can tell you that the younger adults, when I speak of younger adults, they're between 19 and 35 years old, and older adults are typically 65 plus in all of our studies. We do batteries of sensory, mobility, and cognitive testing on all of our participants, and we typically use a lot of these as cutoff points, and so we have a very healthy, typically very healthy group of older adults, unless I specify otherwise. Okay, so we know that driving is multisensory. So when you're driving a car, you may not be aware of all of the ways that you're processing information, but you're processing information about dynamic visual cues, quite obviously, but also the motion of the vehicle and yourself within the vehicle, about sound cues from your environment, including wind sounds, tire roar, engine sounds, et cetera, which are all contributing to your ability to control the vehicle. And so we asked the very basic question, do multiple sensory inputs support driving performance? And are these benefits greater in older compared to younger adults? So we had a visual-only condition where the driving task was super simple, just stay in your lane and meet the speed limit. But there was no objects, there was nothing happening, there was no other vehicles. It was very, very simple. Then we layered in sound, tire roar, wind sounds, engine sounds, et cetera, that ramped with speed. Or we added motion. So we put on the motion base, and then we had vestibular information. We looked at a lot of different things, but I'll just show you speed variability, mean speed, and variability in lane keeping. And so what you can see here is standard deviation of speed. So greater is worse, is more variable. The younger adults on the left and the older on the right. And you can see that both younger and older adults benefited from having auditory information introduced. Their variability went down. But you can see that older adults actually started with quite a lot poorer, more variable visual-only performance. and their bimodal benefit was much greater than the younger adults. When we added motion, the younger adults didn't benefit too much, but the older adults also saw a significant benefit to motion for maintaining their speed. And when we looked at the mean speed, the main outcome there showed that older adults slowed down when auditory information was added, so they modulated their speed as a function of that added input. Then we looked at variability in lane keeping. So we expected that auditory information shouldn't contribute anything to lane keeping because it is not a redundant and congruent indicator of where you are in your lane. But we thought that the motion might, because the lateral movements that you would get may support lane keeping. We saw a small effect in the younger adults. Their variability in lane keeping went down with motion. But for the older adults, it actually went up. So they got less variable in keeping their lane when motion was added. So that was a bit of a curiosity for us because we thought that that kind of goes against what we predicted. But one of the reasons is quite possibly because this is in a simulator. And so even though we have a large degree of freedom in the simulator, we can't map one-to-one the types of physical accelerations that you're getting in the real world. So inevitably, we have to use some trickery, which means there's a slight conflict from what you see and what your motion is telling you. And so it's possible that older adults are more sensitive to those sensory conflicts. The problem with using a realistic task is that there's a lot of other things that come into play here, like life history. So is it the case that that the differences that we saw in older and younger adults was because of greater sensitivity to sensory conflict? Or is it because they have more years of driving experience, so they have a prior or a whole set of expectations about what they see and how their movements are aligned? There's a greater set of expectations that just comes not from age, but from driving experience. And so you can't take life history out of the equation when you're looking at these realistic everyday tasks. So we stripped this down and went more reductionistic. So we thought, okay, well, let's see if we are seeing some similar principles apply in basic psychophysical tasks of visual vestibular self-motion perception. And so here, the simple question was, do older and younger adults integrate basic dynamic visual information and vestibular cues optimally? So do they show this bimodal benefit relative to unimodal benefit? And do they weight the more reliable sensory information higher? Do they use this reliability-based weighting that we talked about? And the task was really simple. It was just a discrimination task. So they would be moved in one direction, and then they would be moved in a slightly different direction. And they were asked, in which of those two intervals were you moved more to the right? So it's just a direction discrimination task. And of course, we would make it so that some of those heading angles were really big, and then we would reduce the heading angles between those two intervals until they were very, very small, and that would give us an indication of if people could still judge the difference between them at those very small heading angles being their threshold. Then lower thresholds means that they're more sensitive to be able to discriminate between those two heading directions. And so we did this in a visual-only condition, a vestibular-only condition, and then with combined inputs that were congruent in this case. And so they would both see the optic flow display and they would be accelerated and moved physically. And so the expectation here, I don't know if we can use my cursor yet. The expectation here is that we would plot this, so the movement angle, if it was really big, so minus 20 degrees to the left, or plus 20 degrees to the right. Those are really big differences in angles. 20 degrees to the right, they should pretty much 100% of the time say they were more rightward, because it's a big angular difference. And 20 degrees to the left, 0% of the time they should say more rightward, because it's very clearly to the left. But then when you get into this area here where they're starting to come very close together, this is a very sensitive area on the curve to be able to determine their essentially the reliability in which they can make these judgments. So we would expect that you've got the visual in blue and the vestibular in pink. We would expect that this gray bar, the combined bar, would actually result in better precision than either of those unisensory alone. So the combined, the gray should be steeper than the other two. But we also tricked them a little bit because we were very interested in this question of how do they react to conflict. So we did a small conflict where physically they were moved straight ahead, but visually we showed them that they were moving 5 degrees to the right. Or physically they moved straight ahead, and we did a large conflict where they moved 20 degrees to the right. And so we wanted to see whether or not their estimates would align with the visual presented motion or the physical presented motion. And so very quickly what we found was that when we had just the vestibular cues alone, when they were just passively moved in the dark, the older adults and younger adults were able to estimate these things equally well. Vision alone, very interestingly, and this is a repeated pattern that you'll see throughout my talk, is that older adults, so they were less precise older overall. Younger were more precise than older adults, but 25% of older adults could not even do this task. So if we just showed them the optic flow information and asked them to discriminate these two different intervals, they couldn't do it. They had essentially a flat curve. But when they were combined in congruent, both the older adults and the younger adults did integrate optimally. But perhaps the most interesting thing is that when we introduced those subtle sensory conflicts, no longer did we see optimal integration or bimodal benefits for the older adults, whereas they persisted with the younger adults. It wasn't until the big conflicts came into play that the older adults stopped integrating. So we saw a little bit of obligatory integration in the face of conflict. And then while younger adults always weighted the more reliable input higher, in this case it was the vestibular input, older adults persisted in giving the visual information more weight than they should have. So it was a very unreliable cue based on their unisensory estimates, but when we created a subtle conflict, they were drawn to that conflict when they were estimating their heading direction, which would not have been the optimal way of doing that. So then we thought, okay, it's interesting that we're seeing, especially in that visual-only condition, that a lot of older adults had a lot of trouble with this. So can we train multisensory self-motion perception in order to make people better? So very simply, the objective of this study was to ask the question, can the precision and accuracy of self-motion perception be improved with multisensory training? And particularly, we were interested in visual self-motion perception because that's where we saw the biggest troubles. And then, of course, we would expect that older adults might have more to gain from training than younger adults because they were poorer to begin with, and because they typically benefit more from having multisensory inputs. So the task was exactly the same as the one that I had just described to you, vision only, vestibular only, passive movement in the dark, and then multisensory congruent. It was only congruent here. We never added any conflicts into this situation. So they did that first so we could get their visual only precision, their vestibular only precision, and their combined precision before they did anything else, before they did any training. And then they did, over 3 days, 900 training trials where we moved them and we just asked them to say, did you move to the left or did you move to the right? And it was right around their threshold because we didn't want to make it too easy, we didn't want to make it too hard, and they would get feedback. So it was correct or incorrect depending on if they said right and it was right, it would be correct, left, they said left and it was actually left, they would get correct. So they would get this feedback over the course of these 3 days. And so I'll walk you through this graph. So here's precision. So actually, in this case, it's actually variability. So higher is, again, worse. And you'll see older adults on the left and younger adults on the right. And in the kind of muted tones, that's the pre-training values of precision. And then in the darker, more saturated tones, that's the post-training. And you can see, generally speaking, for both older adults and younger adults, when you're looking at the bimodal trials and the vestibular-only trials, there's a little bit of benefit. These are not significant after training. But where you see the biggest benefit is in the visual-only condition. So you can see with the older adults, their visual-only, as we'd seen before, was quite imprecise. With multisensory training, with perhaps that vestibular information calibrating the visual information through this combination, reduced the variability. And we saw this in younger adults too, but to a greater extent in the older adults. And of course, the curiosity was, well, maybe it's not multisensory at all. Maybe if you just trained them with the vision-only task, that they would have done just as well and improved in vision. But what we found was that when you did just visual only, it wasn't significant. The pre-training, post-training effects, if we just trained with visual information, 900 trials, feedback and everything else, but not moving, just stationary visual dynamic flow, they didn't get the same training effects. So it does seem like there's something unique about having that visual information paired with the movement that allowed them to improve their visual-only precision. Okay. So in this case, 27% of older adults could not do the visual-only task, similar to the 25% that we saw in the last study. We did see that precision improved with multisensory training, but only for the least precise sensory input, the vision only. And that maybe this had to do with some sort of calibration or adaptation process that allowed the less reliable sensory input vision to be calibrated with the more reliable sensory information vestibular. And that visual training alone did not lead to the same improvements. Okay, so now I'm going to switch gears. I always feel weird when I say switch gears after talking about driving, so no pun intended. But I'm going to tell you about some of the work that I'm really enthusiastic about that's looking at the effects of hearing loss on mobility and falls risk. And I think it's interesting because you don't think about hearing as being that important for mobility. So when you think of risk factors for falls and you think of like a lot of falls prevention campaigns, you don't think about people talking about getting your hearing checked. Vision, sure. Muscle strength, sure. Make sure your environment is bright and that you're not on improper medications and a lot of these other things. You don't really think about hearing per se. But interestingly, when you ask people who have hearing loss, this is a Statistics Canada result, individuals with hearing loss commonly report limitations related to mobility and agility at 65% compared to limitations in communication and memory. And you think of hearing as being primarily important for communication. So this is very telling. But there was a couple of large epidemiological studies that show consistent findings that individuals with hearing loss, particularly age-related hearing loss, are at 3 times greater risk of falling than age-matched peers with normal hearing. And there's a dose effect here. So for every 10 dB increase in hearing loss, there's an additional 1.3 times increase in risk of falls. So there's something interesting that's happening that we don't really understand mechanistically. Why is it exactly that hearing loss is so consistently associated with falls risk? So there's a lot of different hypotheses here. I highlight 4. The first one is, poor spatial hearing. That seems pretty intuitive. So if you have hearing loss, maybe you cannot localize the sounds around you that can aid in your orientation and navigation, and that may compromise your mobility or your safe mobility. It could be that you have parallel vestibular loss. So the auditory system and the vestibular system are co-located in the inner ear. They work in similar ways. They have shared nerve inputs to the brain. So maybe when you have declines in your auditory system, you also have declines in your vestibular system with age. Oops. It's also possible that it's related to higher cognitive load. So when you have hearing loss, listening becomes far more effortful. So you have to put a lot more cognitive resources towards listening and hearing, and that could be at the expense of other things that you're doing at the same time, including mobility-related tasks that could put you at risk. And then social isolation is an indirect link that has been talked about, which is when you have hearing loss, a lot of times you become less social. You stay at home, you don't go out, and what that can do is it can contribute to cognitive deconditioning and physical deconditioning. So if you are not exercising and stimulating your brain by going out and socializing, then that's going to have adverse effects, and those are all risks for falls as well. So the first one that I'm going to talk about, I'm not going to talk about all of these, but I'll talk about 2. So the first one I'll talk about is it the case that older adults with hearing loss actually have poor vestibular sensitivity. And so, in this study, the objective was exactly that: is vestibular perception poor in older adults with hearing loss than older adults with normal hearing? And we also ran younger adults in this study as well. And in this case, we had people in a box, quite literally, where they were. We wanted to really limit proprioceptive information that you might get when you're being moved around. We really wanted to move people passively, but primarily stimulate the vestibular system. So we fixed their head and strapped them down. It was very comfortable. I don't think they felt too intimidated. Took away all the visual information, turned off the lights, etc. Noise-canceling headphones. And we would put them on the motion platform, and then we would move them in either heave or in pitch. So sort of bouncing them up and down or pitching them forward and backward. And I always joke that the biggest challenge during this study was to keep people awake because it's very relaxing. It's a very... Okay, and there were the three groups. There were the two movement types. And again, here we use psychophysics. We use an adaptive staircase procedure, and we asked in which of the two presented intervals did you move more? They were presented once, they were presented a second time, and they said in which of those two were you moved more? And again, we started off with really big differences so that the two movements were clearly different, and then we reduced the magnitude between those two intervals until those magnitudes were very tiny, and we looked at their threshold. So at what was the smallest difference in the magnitude of motion that they could detect, and that was the threshold that we were interested in. So here's what the heave motion looks like from the exterior of the motion platform. It will move. So it's like a built-up sinusoidal motion profile. See, it's almost relaxing just watching it. So it would do one, and then it would do two, and then it would ask them to respond with which was larger. So here comes the second one. You visually will not be able to tell the difference. It's much easier to physically detect it than it is to visually detect it. So what we found here is that when we looked at the heave discrimination, and again, higher threshold is worse, it's less sensitive. We didn't actually see a significant difference across our groups of older adults with hearing loss, normal hearing, or younger adults, but there is a pattern there. But we did see it in pitch discrimination. So older adults with hearing loss had significantly higher thresholds in pitch compared to older adults with normal hearing and younger adults. So then we were also under the assumption that, those were effects, but they're not giant effects. They don't have dramatically poorer vestibular sensitivity. And it's probably more logical and likely that there's a few contributing factors at play here with respect to falls risk. So we wanted to know, does higher cognitive load also contribute to poor balance, for example? So we looked at a dual task listening while balancing paradigm under these realistic conditions. In this case, we used StreetLab, our multisensory immersive virtual reality environment. And we asked, are there age-related changes to dual task costs when having to listen while performing a standing balance task at the same time? And we chose a listening task that was intended to challenge central auditory processing abilities that would be most likely to be experienced with people with hearing loss. And in this case, we started off just looking at typical age-related changes, so not necessarily starting with looking at older adults with clinically significant hearing loss, but with sort of age-related changes to hearing that were typical. And so they would be standing on a force plate in the middle of the lab, and so we would be measuring posturography, looking at center of pressure, sway variables. And they would also be completing something called the dichotic digits task, which is multiple speakers speaking digits at the same time. So there was either no listening task, that's single task standing, or there was a dual task. Low listening load, which, if you can hear it, is just 2 digits.
3, 4,
Can you hear which 2 digits?
1, 5,
it's hard in the speaker system. Do you feel like you can hear them both?
5,
Okay, so in the case in the lab, they're being spoken from 2 speakers, one towards
6.
each ear. And
5,
and you have to be able to hear them simultaneously, segregate them, and then repeat them back. And then the high load was 4 digits, 2 sequential pairs.
4, 1, 4, 3,
Okay,
4.
so not like super easy, a little tricky, but it gets easier. So the measures were listening accuracy and postural stability. So I'll just show you here center of pressure, path length. And so here I'm presenting dual task costs. So anything above 0 means there's a cost associated with it. It's worse if they had to do 2 things compared to 0, which is when they had to do 1 thing. And here we're looking at dual task cost to posture, and we see older adults on the left and younger adults on the right, and we see low listening load in yellow and high listening load in pink. And what you can see right away is that for older adults, there is a little bit of cost to their posture. They get a little less stable, a little more sway when they have to listen with low load listening task and stand at the same time. But once that listening load became higher in that 4-digit condition, they showed a lot greater costs to their posture. So they had a lot more postural sway, increase in postural sway compared to when they didn't have to listen at all. The younger adults, there was no cost at the low listening load, but there still was a cost at the high listening load. It just wasn't as high a cost as it was for the older adults. When we look at dual task costs to listening, we actually see that the older adults, so this is when, so it's not perfect, so single task posture is, or single task listening is just sitting compared to dual task, the postural manipulation is standing. So sitting is you're not doing anything, that's single task. And standing is now you have to do something posturally, you have to stand and manage that. And you can see that when older adults were in the sitting condition, they actually had a slight benefit to listening. When they had to stand on a compliant surface, then you started to see that they experienced some costs to listening as well as their posture. So even being able to manage or prioritize the 2 tasks, they were experiencing costs to posture and also costs to listening. So it wasn't like they were experiencing cost to posture while protecting listening once it became too difficult. The younger adults, you see that, but not as pronounced. Okay, so yeah, now we're doing a lot of different work to look at interventions, right? So one thing that people often ask that's top of mind is, well, what if you used hearing aids? Do hearing aids help? So hearing aids are not very good at preserving spatial cues, so they're not going to help you with those sort of binaural sound spatial cues to keep you oriented, but they may reduce that cognitive load or that listening load through amplification that may then also relieve the costs on balance-related outcomes. So we're investigating this now. The sneak peek is that hearing aids don't seem to do much. There are some caveats to that, but we don't see remarkable benefits in aided versus unaided conditions. So I just have one last study to talk about. And this is some newer work that we're doing looking at individuals post-concussion. And again, focusing on visual self-motion perception. But in this case, we're looking at vection. And vection is the subjective feeling of moving when you're not really moving. So if the classic example is the train illusion, where you're sitting on a train and the train beside you starts to move, but your train is stationary, and you get this compelling sense that you've just started to move until you snap out of it and realize that it's this global visual motion that created that illusion. Or if you drive standard like I do, which you probably don't, I start to drift backwards if my foot isn't on the brake, and sometimes I interpret it as the car beside me crawling forward, and I have to slam on the brake really quickly, realizing it's me and not them. So these are examples of vection, but also vection is typically desirable in virtual environments. So sometimes when you're playing video games or whatever, if you want to create a sense of presence, you might want to introduce vection so that people feel, or in an IMAX theater, so that people feel like they're actually moving. So it can be a fairly compelling sensation. But we were interested in using it as a tool to understand how people post-concussion are processing dynamic visual information. And this was motivated because people with concussion often report that in moving or complex environments is where they experience triggering symptoms, or it causes a trigger of symptoms. And a lot of times this is attributed to this increased visual dependence that comes with some sub-classifications of concussion. That means that these dynamic or complex visual cues are being upweighted more than they should, which is causing disruptions to sensory integration and can cause disorientation and dizziness, for example. I already explained what vection is, illusory self-motion. So the objectives here were to see, quite simply, are vection ratings higher in persons post-concussion versus controls? And is greater vection intensity associated with more postural sway? So it's not just a matter of do they perceive it visually, but is it also affecting their behaviors? Are they starting to lose stability because of this increased responsiveness to visual motion? So here we had concussed participants and controls. They went through this grocery store aisle. This is a very bad picture because it's warped, but from the person's perspective, they're going down a grocery store aisle, which is a common scenario that people will complain about post-concussion. They moved 30 seconds at 11 different speeds, and we asked them to rate their intensity of vection at the end of their travel. And we also measured their postural responses to this visual motion while they were standing there. And so we have the visual optic flow speed on the x-axis and the vection ratings on the y-axis. And you can see quite clearly that vection ratings increase with speed, which is what we typically see, but that the concussion group had higher vection ratings overall, the concussion group, higher vection rating overall than concussed. And then if we look at how this affects behavior, the postural sway, then you can see that for the concussed group, and these are just individual subjects plotted and then the average in green, you can see that, that the amount of sway that was increased as a function of this ramping up of visual speed was much greater in concussion than control, which really didn't see a lot of postural compensatory adjustments in response to this visual stimulation. Okay, so overall, in summary, I told you that older and younger adults optimally integrate multisensory information in the context of supporting self-motion, both in terms of perception and behavior. We saw this in basic psychophysical tasks, and we also saw evidence of this in more complex behavioral tasks. There was this consistent finding that there was poor self-motion perception and heightened multisensory integration in older adults across these tasks. That cross-modal training effects do seem to have some influence on improving self-motion perception, especially visual. Hearing loss is associated to some extent with poor vestibular perception, and that there's this dual task effect of listening while balancing, which is also probably an indicator of the demands that people have to manage when they have to listen and support safe mobility at the same time, which we've since also looked at in older adults with hearing loss and also see that this is compromised. And then individuals with concussion experience stronger perceptual illusions of self-motion when physically stationary compared to controls, showing that, again, increased evidence for this visual dependence that is affecting them both perceptually and behaviorally. So I hope that I've convinced you that studying the brain in complex, multisensory, dynamic, changing, realistic, and reductionistic ways gives you some valuable insights into the processing of this information and how it supports us in our everyday lives. So thank you so much.
Okay, we have 1 minute for questions. So if there's one really good question that somebody wants to ask, we can entertain one question. Tyler?
Did you have data on if the participants with hearing loss had tinnitus?
Yes, so we use tinnitus as an exclusion criteria. So if they had tinnitus, so I can't tell you if it would have made a difference to our outcomes because it was exclusionary. And it's a general limitation of all of our research, which is that we test people who have been screened for really common, screened out for very common age-related conditions. And so I suspect that what we're seeing here is a conservative estimate of what we would see if we included everybody who had typical common age-related comorbidities and conditions.
Okay, so there is a reception up in 205A, and Jenny's going to be around for the next hour or so. So if you have any questions or about the talk or about her amazing research or about her, please come and join us for a reception. And let's